Hello, and welcome to the Feeling Good podcast, where you can learn powerful techniques to change the way you feel. I am your host, Rhonda Borowski, and joining me here in the Murrieta studio is Dr. David Burns. Dr. David Burns is a pioneer in the development of cognitive behavioral therapy and the creator of the new teen therapy. He is the author of Feeling Good, which has sold over 5 million copies in the United States and has been translated into over 30 languages. David is currently an emeritus adjunct professor of clinical psychiatry at Stanford University School of Medicine. Hi, David.
Hello, Rhonda.
I got the hello in first this time.
Yes, you did. Hello, Dave.
Hello.
Frybush.
Frybush. Oh,
yes, we have the wonderful Dave Frybush with us.
I had it wrong all this time. Hello, Dr. David.
Hi, David. Good to be here. I always enjoy talking to you.
We've got the three Davids and Rhonda in today's podcast.
Surrounded by Davids.
And we've got some fantastic stuff on physical pain. We've been talking about emotional pain for 165 podcasts, and now we're going to turn to physical pain.
I always say this when I'm super excited about this episode and really happy to welcome David Hanscom.
Correct.
I'm sorry, I mispronounced. And he's an orthopedic surgeon for 32 years.
Right.
And you specialized in complex spine surgeries.
Correct.
And then you went through your own experience of chronic pain and eventually came up with a new formula for treating pain besides surgery and wrote an incredible book called Back in Control. And you've produced videos and you have your own podcast that David has been on a couple of times.
Right.
And we wanted you to come on the podcast to talk about your experience.
Well, I'm excited to be here. It turns out that cognitive behavioral therapy has been a huge factor in the process that evolved in my situation. And I went to one of the top spine fellowships in the world, Minneapolis, Minnesota, back in 1985-86. I came out of there on fire that I was determined to solve the worst problem with spine surgery. I would actually feel guilty if I could find a reason to do surgery. When I hit Seattle, Washington,
You felt guilty if you could
not find a reason to do surgery. I just felt like that's what I could do, was to do surgery.
And you went to a top training center.
Right.
Uh-huh.
And I felt really good about that. I was a zealot, really, about doing spine surgery. But I was always fastidious about working medications, and I didn't understand psychosocial issues, even though I know they were important. I do remember as an orthopedic resident looking at a paper that said the prognosis for spine surgery had more to do with psychosocial issues than the actual anatomy. I'm going, what? That caught my attention back in 1984, many, many years ago.
So just to repeat that for our listeners, because I want to make things as simple as possible. What was that, Rhonda?
He wanted me to give him a sign if he was talking too fast. And I think he's
talking too fast. Oh,
Right.
I see. That was
She wasn't
the
disapproving.
middle finger salute, was that?
Right.
No,
She
that was the
wasn't-
thumbs,
No,
the
we already
thumbs
worked that
down.
out in
She
advance.
wasn't disapproving of me.
No, not
but
at
you
all.
were saying that you saw a paper that indicated that the outcome from a spinal surgery, this is huge. Later, I'm going to tell you about a comment one of the top Stanford researchers made about something called fusion surgery, spinal fusion surgery. But at any rate, you read a paper that said that psychosocial factors, in other words, your relationships with your family, your emotional well-being, had more to do with the outcome of surgery
Right.
than the actual anatomical problem or the severity or presence or absence of the anatomical problem. Is that what you said?
That's correct. That was my first clue that something wasn't right. But I'm just thinking, well, this person must be faking it. They must not be really for real.
You didn't believe it.
Well, we're taught as surgeons that the way to deal with disability and chronic pain is to be tougher. In other words, we set up strong boundaries. People can't cross them. Somehow it's going to heal people. Wrong.
What does that mean, to set strong boundaries?
Like, for instance, workers' comp, the general flavor still is among surgeons that, well, this person just doesn't want to work.
Oh, uh-huh.
Right?
Right.
And so the idea is you set really strong, firm boundaries, and that was right in there. That we set really strong boundaries, there'll be less disability. What I didn't realize is that...
What does it mean, though, to set firm boundaries with someone who's trying to get disability? It means you do surgery or you don't do surgery, or what? I just want to grasp what you're saying.
You don't allow them to get on disability in the first place. In other words, you create so many hurdles to become disabled that they just can't do it.
Oh, I see.
And the surgeon should say, no, you don't need the surgery. And then there's like 5 other review papers that came out over the next 10 years saying the same thing. When I hit Seattle in 1985, we were doing 9 times the rate of spine surgery per capita as any place in the entire country. These were fusions for back pain. And I asked my partners one day, I said, well, what's the data? And they go, well, we don't know. In 1993, a paper came out from the state of Washington that showed that the success rate of a spine fusion for back pain in a workers' comp patient was 15%, 1-5.
Wow.
Oh, wow.
I thought it was 90%, and I just stopped. I didn't know what to do, but I immediately just stopped doing the operation.
That's what I was going to mention, the fellow at Stanford. I'm trying to think of his name. He's a brilliant mathematician, MD, researcher. He's one of Stanford Medical Center's top researchers, and he had an article in Stanford Magazine about 5 years ago. He was on the cover of it. One of the things he was talking about in psychiatry and medicine and surgery, how a lot of things are peddled for money that have nothing other than placebo effect. He was talking about antidepressants and various things. And one thing he mentioned was that all these centers for spinal fusion surgery,
Right.
and that it really, the data indicated it wasn't any different from placebo.
Well, Dr. Eugene Karagi is the orthopedic surgeon at Stanford who put the nail in the coffin in 2006. He did a 5-year study looking at back pain infusions. He had very carefully selected patients that he did 1-level fusions on. He compared those with patients who had very grossly unstable spines. He found that the success rate for a spine fusion for back pain in a very carefully selected patient was 22%.
Wow.
And that was it. I mean, I had already stopped, but it was such a carefully done study. Then it turns out that there's actually no connection between disc degeneration and back pain. We don't know what causes back pain. We actually do know that disc degeneration does not cause back pain.
Yeah, right, exactly.
Degenerative disc disease is not a disease.
Yeah.
It should be called a normally aging spine.
Exactly.
Right? And then I wrote this book that's going to be released next month called Do You Really Need Spine Surgery? It puts people into 1 of 4 quadrants. Either there's something there to fix or not. I call it a structural problem versus non-structural. Either I can see it or I can't. And then the A versus B, is your nervous system calm or is it hypervigilant? Is it stressed? And if you are a calm person with a ruptured disc, you'll do fine with surgery.
But just to simplify that, if you're not emotionally upset, you're relaxed, but you have intense physical pain that can be related to an actual lesion,
right,
then you're going to have a high likelihood of a good outcome from surgery.
Correct. But if you have the same lesion and you're stressed, it doesn't mean you shouldn't do the surgery, but you also have to calm down the nervous system. You've got to deal with both. The problem right now in spine surgery is that we have people without any identifiable lesions, nothing, and we're doing these, and their nervous system's on fire. They're extremely stressed out. They've been bounced around the medical system. They're the group of people that we're doing procedure after procedure after procedure on, and it doesn't work. There's 2 papers out this year showing that we look at randomized prospective studies on any surgical intervention in any part of the body, heart disease, back pain, knee pain, whatever it is, none of them work in chronic pain because chronic pain is different. When you have acute back pain, it goes to the pain center. They have these research MRI scans now called functional MRI scans. And with back pain, it's called the nociceptive pain or the pain center, that if you have acute back pain, that lights up. For people that become chronic, the pain center always goes quiet. By 12 months, it goes only to the emotional center.
Wow.
The definition of chronic pain is completely different. Chronic pain is completely different than acute pain.
Can I ask you to repeat that in English? Remember, everything for me has to be at the 4th grade level. And remember that half of our listeners have IQs under 100. You know how I figured that out?
How did you figure that out?
Because 100 is average.
Yeah, right. 100 is average.
Right.
And so some of us with IQs that aren't quite so high, what you're saying is incredibly important, but just put this, like imagine I'm a 4th grader and explain it to me once again.
Which part of it?
How chronic pain is different than acute pain.
Okay, so acute pain, in other words, you stub your toe, you hurt your back, It's called the nociceptive system.
No, that's called the acute pain, the right now pain system, not that other stuff. Don't use those other words.
So pain protects you.
Yeah.
People that are born without pain fibers actually don't survive past age 10.
Oh, right, yeah.
They can't survive. It's called congenital indifference to pain.
Wow.
They did these research MRI scans where they can look at activity of the brain with these very special, now more granular scans. It's called functional MRI scans. If your pain persists after 6 to 12 months, the pain center drops to 0.
The activation in the part of the brain that's one of the areas involved in pain, it's
Right.
no longer active.
Correct. Then the emotional center lights up.
Okay, your negative emotion part of your brain
Right.
lights up, meaning it has more blood supply, more firing of nerves.
Right. More glucose metabolism.
Yeah.
Right. The brain runs on glucose or sugars.
Yeah.
And they can label these sugars and find out which part of the brain is metabolically active.
And what part of the brain is that's emotionally activated?
Well, it's more regions now.
Mm-hmm.
They're looking at patterns of activity
Right.
more than, say, like just the amygdala, stuff like that. So it's sort of patterns of activity.
Mm-hmm.
It turns out that emotional pain, from multiple other studies, emotional pain and physical pain are sensed in the same part of the brain.
Yeah, right.
Period.
But what you just said is, with chronic pain, the part of your brain that normally would light up when you stub your toe or when you cut yourself accidentally, after 6 months, that part of your brain, quiets down and doesn't light up.
Correct.
But what happens is the part of your brain that registers emotional pain, that begins to light up even more.
Correct. And so what happens? You have the same pain, but a different driver.
Mm.
And people say, well, you're saying the pain's in my head. That's the only place pain exists, because your brain right now is interpreting sensory input. I'm unconsciously shifting to my chair so my skin doesn't break down. I'm not staring into that light. What your brain does, it keeps you in a range of behaviors that's safe. When you see that range, your brain says danger. When you feel pain, it simply says danger. Pain is not on this table unless I butt my head on it. In other words, my brain has to interpret the sensations, and then it says danger. That's pain. And what happens if you feel pain, in other words, your brain automatically keeps you in a range of behaviors that's safe. When you are uncomfortable, then your brain says danger, or you feel pain or anxiety. Turns out, since emotional pain goes to the same part of the brain as physical pain, the mental pain is the bigger problem because you can't escape your thoughts.
You can't escape them.
You cannot escape your thoughts. Humans
Yeah.
cannot escape their thoughts. My cat can just escape the predator, but my cat's not thinking about tomorrow or the next date. Humans have the problem with these thoughts, which, as we know well, cognitive distortions that go to the same part of the brain as a physical threat. Since you can't escape your thoughts, then your body's now hypervigilant. It changes the body's chemistry. Instead of being full of oxytocin and dopamine and serotonin, which are the fun relaxation hormones, you're full of adrenaline, cortisol, and histamines, which are the stress hormones. You're in hyper alert, which, by the way, one of the effects of hyper alert is it doubles the speed of conduction. The nerve conduction is doubled, which makes sense because you want to protect yourself. You feel the pain more. You physically feel the pain more when you're under stress. The key to the whole process, by the way, of solving chronic pain is connecting to your own capacity to heal, which allows you to regulate your body's chemistry from a stress profile to a relaxation profile. And your general contentment in life is really based on your body's chemistry. The reason I actually quit, first of all, going back to my story, I quit doing surgery in 1993. About that same time, I plummeted into chronic pain myself. And it started with a panic attack.
What year was that?
1990.
A panic attack and then pain, chronic pain.
Well, it turns out that I didn't recognize it as chronic pain. But what happened, I was driving across the 520 bridge in Seattle, Lake Washington Bridge, 10 o'clock at night. I was so good at mastering stress, suppressing anxiety, I didn't know what it was. I had to look it up in a dictionary one day. What's anxiety? I didn't know what it was. I went from no anxiety to panic attacks in one day. And for the next 15 years, I couldn't control it. And what happens is anxiety is simply a description of elevated stress chemicals. And it's got psychological implications, but what happens, you have a mental threat, goes to part of the brain that says alert, but you can't escape it. So what I had done, I was so good at suppressing stress, I had no idea. We can talk about how cognitive behavioral therapy affects that, because you should be switching sensory input, but the bottom line, I was suppressing stress to the point that I didn't know what was going on, but my feet were burning, my ears were ringing, I had migraine headaches, I had neck pain, back pain. It was my whole body was full of these stress chemicals on a sustained basis for over 15 years. The problem is you can't escape your thoughts. You have sustained elevations of these stress chemicals. It translates into real physical symptoms. I ring into my ears for 25 years. I never thought that would be gone. And you talk to people that have tinnitus or ringing in their ears, it's a horrible symptom. It's gone.
Wow, that's amazing.
Well, again, the nerve conduction improved, right? In other words, my threshold for these ears ringing changed with my body chemical changes. So when people say, well, you're saying the pain psychological, no. The sensory input in the presence of in the form of cognitive distortions. You want to put that in a different, simpler term, David?
Well, I'm trying to figure out what you're going to say, so I can't put it in simpler terms until I get it.
Okay, in other words, you have these unpleasant thoughts.
Yeah, negative thoughts, and you're upset, you're depressed, you're anxious, you're angry, you're in an agitated state.
Right, and everybody knows that your heart's racing, you're sweating. It doesn't just happen. So the part that people have missed, and it's right there in front of us, I'm not going to claim original insight into this, is that thoughts translate into body chemistry changes, which has an effect on every organ in the body. That's why, since there's so many different unique organs, there's over 30 symptoms of an adrenalized cortisol nervous system. For instance, autoimmune disorders. The study just came out of Sweden showing that there's a very strong correlation between chronic stress and autoimmune disorders. Rheumatoid arthritis, colitis, Crohn's disease. All these things are connected with chronic stress. The diseases don't just happen. I mean, why do they happen? Because it changes the cortisol, it changes the histamine levels, and so there's a very high instance of autoimmune disorders and chronic stress.
And then is there any research about why someone would get rheumatoid arthritis and another person would get colitis?
That part we don't know.
We don't know
That's
that.
the part I can't. I mean, in other words, I had 17 of these 30 symptoms at the same time. There's over 30 symptoms of an adrenalized nervous system. I had 17 of them at the same time. Nobody could tell me what's going on. I was in a lecture in 2011 by Dr. Howard Stumer from Detroit, who talked about this whole idea of the stressed out nervous system and the physical changes. And I started looking at his list of 33 symptoms, and I'm going, wait a second. My wife was sitting next to me at the time, and she started poking me, and I'm looking at this list and going, really? I had 17. And all of a sudden, within 10 minutes, the entire 15-year journey started to make sense. And I started sharing those tools with my patients, but I wasn't...
What tools?
Well, just simple things of how to just calm down the nervous system. In other words, if anxiety is simply a description of your elevated stress chemicals, the way you decrease anxiety is you decrease the stress chemicals. There's a tool called expressive. So David's book, by the way, was a major factor in me getting better. I started coming out of this process in 2001 where I happened to pick up your book, Feeling Good. I started the writing exercises, and I thought it was the book. And the book is a wonderful book. The 3-column technique is a wonderful technique, but in addition, it also shows that the writing exercises, David said to write, so I started to write. I didn't know what else to do. After 15 solid years of anxiety to the point of developing a full-blown obsessive compulsive disorder, things started to break within 2 weeks. I'm going, wow. And by 6 weeks, I would say my anxiety was about 70% better. My feet at that point were burning so badly I couldn't even put into words how bad it was. The intrusive thoughts were coming at me so hard, I was just absolutely at the mercy of these things. I was suicidal. I'm pretty clear about that in my book. And within that 6-week period of time after I started the 3-column technique, things started to change. And I will admit that I would write for hours at that point because it was it's like I get out of jail. And I didn't know about
Do you remember what kind of negative thoughts you had at the time? I think
well,
what you're saying is fascinating and really important.
I mean, professionals, I don't want to say just surgeons, but I think a lot of professionals under a lot of stress, whether you're a general practitioner, family practice, whatever it is, there's lots of demands in medicine these days. Being a spine surgeon is considered one of the toughest professions ever because people expect perfection. It's technically a very challenging job. Our surgeries are 8, 10, 12 hours long. We're standing there the entire time. So I just was incredible at suppressing stress. And we're perfectionists. We're criticized all the time. So it's a negative self-talk. I'm not good enough.
Let me write these down. These are so good. I'm not good enough.
Well, the biggest one is that I could have done better, or the case went really well, but I could have done a little bit better. God forbid you get a complication, which we do. And there's a 40% instance of significant depression after a major technical complication.
Wait, from the surgeon or the patient?
The surgeon becoming depressed. Now the thing is so hard when spine surgery goes well, it goes beautifully, and patients do really well. Everybody's excited about it. But the same type of patient that comes into your office with a surgical complication, they don't do very well. You know what could have been. You understand what was possible, and all of a sudden they're in your office with a dural tear, a foot drop, something bad happens, people die. And every spine surgeon, it's a tough deal. Big blood losses, big operations, big complications. And the saying was, well, big surgery, big complications. Well, guess what? The surgeon doesn't really think that way. When the complication happens to you, it's terrible. So the not good enough becomes self-flagellation in a terrible way that I could have done better.
Oh, yeah.
And then, of course, the should thinking becomes brutal. In other words, I should have done this. Why did I do this? I had one gentleman in 1997 who went blind. Surgery went
surgeon?
Perfect. The patient went blind. It's one of the known complications of spine surgery. And now what's disturbing to me even more is that my rehab of getting people better without surgery become so refined and so good. This guy never needed surgery. I could have easily rehabbed. What I didn't know back then, he came to me about 5 years later for a little bit of a rod removal. And I'll never forget.
Removal of a rod from his spine.
Well, his rod had broken and was prominent, so I just had to do about a half-hour operation. I'll never forget this person because, first of all, I thought I was going to get sued. Obviously, major complication. He didn't do that. He walks in about 3 months later. He said, "Look, this is the deck of cards I was given. I'm going to play it." Just said, flat out. Remarkable guy. Then I found out 5 years later that he's going through a horrible divorce. He married a younger woman who's trying to take his estate. Extreme stress. And see what happens now, particularly when medicine moves so quickly, we're not talking to our patients as much. And so we just have to ask our patients one simple question is, what's going on? That question is unbelievable. It doesn't take a big psychological interview to do this. But a simple question is, what's going on? I mean, one woman, what was going on? Her daughter was having a baby. Her husband was the father. That's stress. So the diagnosis isn't neck pain. The diagnosis is really untoward family circumstances. Probably 80% of the time when we ask that simple question, remember that bone spur has been there for a long time. All of a sudden the bone spur has become symptomatic. What changed? Well, stress, tough circumstances, it changes the body's chemistry.
So you're saying, if I can just simplify it a little bit for our listeners, is that doctors are trained to prescribe drugs, surgeons are trained to do surgery, but many people who go to doctors go with physical symptoms of, say, pain or dizziness or chronic fatigue. They'll go to an internist thinking they're anemic or something. And that a considerable percentage of the time, the problem is not a medical problem, but a human problem.
Right.
And so if the doctor can learn to ask what's going on in your life, are there problems in your life, as opposed to let's do more MRIs, let's do more diagnostic this, or give you this pill or this surgical intervention, if we begin to focus on the emotional problems of our patients and to give them some help to overcome the depression, the anxiety, and the anger,
correct,
in many cases we'll see an improvement or sometimes even a complete elimination of the pain.
Well, how do you think, I'm just curious how you think patients would react to that, because I would imagine a lot of times patients come in and they want they want to believe that there's like a specific physical problem that can be solved with
Well,
medicine or
when
surgery.
I was working on the Stanford inpatient unit with the daily cognitive therapy groups, they had a pain center there, and so sometimes the severe pain patients would end up on the inpatient unit, and they'd come to the cognitive therapy groups. And I was interested in this issue of the relationship between pain and emotional symptoms. And I developed, I don't know if you use it, but I have a 2-item pain test that can be given, scored and interpreted in less than 5 seconds, and it's 99% reliability,
Okay.
and it's been validated against all the top pain instruments. And so it was also part of the validation study for this brief pain test. But I had data on the patient's depression, anxiety, and anger at the beginning and end of each group. And so I got about 120 patients and just analyzed the data, because I had pain at the start and end of the group, depression at the start and end of the group. This is within an hour and a half period of time, because I started noticing a lot of the chronic pain patients, suddenly they were cured and symptom-free, just like what you're saying,
Right.
of 20 years of pain at the end of an hour and a half cognitive therapy group.
Right.
And so I was able to look at what is the causal effect of physical pain on depression, anxiety, and anger. Because a lot of the pain patients said, I'm depressed because of my pain. And then what's the reciprocal causal effect of any on those negative feelings on pain? And so you have to do a kind of circular causal modeling when A causes B, but B might be causing A at the same time. And what the data showed, and I think we showed it for the first time, is that the reason so many pain patients are depressed, anxious, and angry is exactly what you've been saying in today's podcast. You use different language, but you're saying exactly the same thing, is because there was a powerful causal effect of negative emotions on pain. Like negative emotions magnify the experience of pain. And approximately 50% of the pain that this is on average that people have is due to their depression and anxiety and anger. Now, how do you deal with it? You ask the patient, would you want some help with your depression, anxiety, and anger, in spite of the fact that you're in pain? You don't impose this on them. But if the patient says, yes, I'd love to get over my depression, anxiety, and anger, and then if they did, there was on average 50% decrease in pain. And that means that some of the patients, the pain disappeared entirely in the groups. Some of the patients, although their depression disappeared, the pain didn't change at all. So there was no causal effect. And some of them, it went down on average 50%. But I think it's the first proof that there is a powerful causal effect. And the reciprocal causal effect, to what extent do depression, anxiety, and anger result from their chronic physical pain? There was a causal effect, but it was very minimal.
I without any commentary on, I certainly all makes sense to me, and certainly what David's saying supports all of that as well. I think my just main question is, as a doctor, if someone's coming in describing a physical symptom, I guess my experience has been people can be very sensitive about the implication that there's an emotional or psychological.
Well, I would just tell the patient that my data and my clinical experience indicates there is a powerful effect of your negative emotions on your pain. And it can magnify the pain tremendously. And I've had the experience myself personally, just as you have had. I won't tell the story now, but maybe in another podcast I will. But if you'd like, what I could do for you would be to help reduce your emotional suffering in today's session. And that might have an effect of improving your pain, and it might not. But at the very least, if we can get rid of your depression, you won't be depressed anymore. Would that be of interest to you? So it's saying, here's the tools I can offer you. And
as a psychiatrist,
yeah.
Or do they come to you as a surgeon?
Well,
I know, because it seems so easy to blame the person. Like they come to you for pain, and someone less sensitive might say, well, you're in pain because there's something that you're doing, or there's something that you're thinking, or if there's something the matter with you. When they're coming to you like, hey, can you just do the surgery and make me feel better?
Well, the essence of the solution, by the way, is helping people feel safe, right? And what I found out when I started this in Sun Valley, I was a primary care spine physician as opposed to a tertiary spine surgeon, and I just get to know them. And
You're saying compassion has a role.
It is the key. In other words, everything we're talking about is secondary to simply knowing your patient, compassion. And again, I get that from your work and just my own experience. And I thought I was compassionate, but I was attached to my label of being compassionate as opposed to really being compassionate. So when I went through my own chronic pain, flaming burnout, I was stripped. I was stripped of all my identities. I had to connect to who I was. I was more able to connect to you and talk to you and find out who you are. So I just would find out who they are, what's going on. Most of them weren't sleeping, so we'd work on sleep. I didn't try to explain pain. And I just get to know them. And what I realized looking backwards, I had no resistance. I had maybe 2 people in 4 years that resisted the project. What happened? I had nothing to sell. People in pain want to hold on to their pain because it's powerful. You ask a person, do you want to get out of pain? They go, of course I do. Well, maybe not, right?
Exactly.
Right. And so what happened, I just found out, so what I do now, I know too much compared to back then. I knew nothing back then. I just did the best I could do. And people do go to pain-free, by the way. We have found out very clearly that chronic pain is a curable problem. The only factor that determines success versus failure is openness to change. So without trying to convince them that there's something to buy or engage in, I said, look, you don't have to believe anything. This is not about believing. So I said, look, let's work on your sleep. I'll see you back in a week. I do think what I contributed to people's healing was a structured program with a surgeon's mindset. In other words, I was offering non-operative care, but I was a surgeon. So instead of seeing them back in a month about sleep, I see them back in a week. Are you sleeping or are you not? And so I went right at it. Within 6 weeks, people were sleeping. Then, David, I used your book back then in Sun Valley. I had no psychologist, so I gave them the Feeling Good book. And then I started noticing, well, people either wouldn't read it or people would read it, but things weren't changing very much. But it was the people who were reading and writing actually were the ones that were getting better. Then I adjusted medications, which I never took people off medications. They always came off themselves. Narcotics were never an issue because they had control. Physical therapy conditioning has always been part of it. But the part that's fascinating, which came out of it, was life outlook has everything to do with healing. Because if you're stuck in this morass of pain, and I get it, you're trying to fix a problem, your focus is on the problem, not the solution.
Right.
And so it turned out this life vision and execution of your vision is a pretty big deal. And so there's a whole sequence now that's evolved of actually coming out of the hole, getting some foundational work. Forgiveness is a big deal compared to play, because when you're angry, your biochemistry is way off. When you're at play, your chemistry is optimized. But you can't mention the word play to somebody in pain because you're insulting them. You're not really honoring their suffering. Again, I learned this from David's seminars on Tuesdays, is really what I probably didn't do enough in retrospect is really honor how much they're suffering.
Yeah.
But people
Right.
in chronic pain die early. They die 7 years earlier than the average person.
Yeah. So I like to make things simple. So it seems to me like you've taught us 2 or 3 things today. You may have ideas, Dave, Rhonda, you may have ideas. But first of all, you had at one time a lucrative surgical practice doing spine surgery, but saw articles shocking that the effectiveness just wasn't there. Maybe the outcomes were 15 to 22% of people were really recovering, and that bothered you a lot. A second thing was that you had your own suffering with panic and with negative emotions, and
Right.
you saw in your own body the development of pain and all kinds of physical symptoms ringing in your ears that were making your life miserable, and you saw how emotional upset began to evolve into physical pain, migraine, headaches, and all kinds of symptoms. The third thing you're telling us is that you began to discover that when you learn to relax and overcome your own negative thoughts and feelings, partly from going to lectures and hearing other people speak, partly from reading my book, Feeling Good,
Right.
and also doing the written exercises. And our next speaker is going to talk about the effective written exercises on circuits in the brain.
Right.
But that doing the written exercises, you began to feel less depressed, anxious, angry. Your body began to settle down, and your pain began to be reduced. And the final thing you're telling us is then you made the courageous decision to give up doing all of this surgery and begin talking to your patients, bringing compassion and warmth and healing to what is the problem in your life.
Right.
Oh, your daughter's pregnant, and the father is your husband. My gosh, how horrible is that? Tell me what's going on and how are you feeling? And when patients begin to talk about their feelings and deal with the issues in their life, all of a sudden, not in 100% of cases, but in many cases, the pain improved or disappeared completely.
Correct.
And finally, you're telling us that on a basic science level, if you look at the outcomes of all of this lucrative spinal surgery that's going on, the outcomes are far more related to emotional issues than any actual structural damage in the spine that's corrected by surgery. Is
Absolutely.
that a summary?
Correct. Very, very nicely done.
Thank you.
And
Go ahead.
And the thing that strikes me too is that you divided the patients that you have current, the ones without spinal surgery that you're working with in your new compassionate way, you divided them to 3 people. You gave them all the Feeling Good book, and some wouldn't open it.
Right.
Some would read it but not, dismiss it or wouldn't actively work the exercises, and some really delved deep into it.
Right.
And did the written exercises.
And it was those patients that had the most successful outcome. And we call that, that's just an example of motivation to healing.
Right.
And they were extremely motivated, and they did the work, they put the work in, and they got the results back.
Right.
But also our next speaker is going to show us how those written exercises actually change brain circuits.
Yeah, great.
Microneurosurgery.
Yeah.
Right.
And then Dave, did you want to say something?
I'm actually just curious how you're obviously an incredibly conscientious doctor, but it was a surprise to you when you back in the 90s or whatever, when you first saw the studies showing that the surgery wasn't as successful as you'd thought. And I'm just wondering, how is that possible? How did you not see it, and how do other people not see it? Because I'm assuming you follow up with the patients after you've done a surgery, but if the success rates were that low, how is it that you didn't see it? I guess I don't mean to be critical. I'm just curious.
It's way darker than you can imagine. So first of all, there's not one research paper, not one, that documents that a spine fusion works for back pain. Not one. And with the expressive writing, Dr. James Pennebaker started this research back in about 1982. He's on one of my podcasts, that the expressive writing, he wrote a book called Opening Up by Writing It Down. It has been documented to be effective in over 1,000 research papers. 1,000. Okay, in good research. Okay, so spine surgery is somewhere between $10 to $20 billion a year. That surgery is risky, dangerous, really hurts people. And then I never was taught about expressive writing. Were you? I mean, I wasn't taught about expressive writing in medical school, residency, fellowship, practice. I never heard of it.
But no one makes money off it, but we were taught to prescribe antidepressants that make a lot of money, and if you do surgery, you make a lot of money, and sometimes money blinds you. But it's the same question you could ask in psychiatry, because the data shows that in all psychiatric settings, 65% of patients drop out of therapy prematurely, from psychologists, mental health, social workers, psychiatrists. If you ask psychiatrists how many of your patients drop out prematurely, they'll say 17%. You say, how many of your colleagues do you think drop out prematurely? They'll say 35%. They think they're twice as good as their colleagues. But the actual number is 65%. And you say, how can you believe this, that's so incorrect? And it's something called the Clinicians Illusion. And there's a chapter on it in my psychotherapy ebook, Tools, Not Schools of Therapy. And one way you fool yourself is because you look at the patients you have, like in psychotherapy, the ones who stick with you. See, they're all happy, they're doing well. So you think, oh man, here are all my patients and I'm helping all of them and they're all doing well. And then the ones who drop out, you think, oh, they were kind of resistant, or something like that, or you don't attend to them. It's very easy to get fooled. But his question to you was, how did you get fooled? Or maybe you weren't fooled.
No, I was. I mean, I was really taught to be tough on patients. I thought if somebody you couldn't see it wasn't there. I had an extremely traditional approach. It's still being done now, even more now than ever. A research paper came out last month in the Journal of Pain. Not one procedure in any field, I think I mentioned before, doesn't work for chronic pain anywhere.
Yeah.
No, any of them, not just
Interesting.
spine surgery, any procedure with any part of the body, because it's a memorized circuit that you can't fix with a procedure. The data is right there. We're ignoring the data. There's another paper out of Baltimore shows that only 10% of surgeons are acknowledging the known data that affects outcomes. 10%. That's it.
It sounds like the surgeons are also not acknowledging the experience of the patients.
Correct.
Right. I mean,
Right.
otherwise they wouldn't need to go to the data.
But money,
Right.
money talks, that's why we have the opioid crisis too. This is a topic for another day, but when you're making money, it's hard to see the truth. You want to see what you believe, what's putting money in your pocket. We want to thank you for this fantastic
Are there other doctors that are
today.
learning? Oh, I'm sorry.
Well,
Are you able to train other doctors to do?
I am. I
with
mean, I'll
your
just
approach?
finish off with saying that, I actually quit my spine surgical practice in December, really at the peak of my career, having a wonderful time. But obviously 3 to 5 patients every week badly damaged by spine surgery that they didn't need. So I wrote a book called Do You Really Need Spine Surgery? It'll be released in October. I have a website, backincontrol.com. We watch hundreds and hundreds of patients go to pain with a largely self-directed process. It doesn't take a big pain clinic to do this. And so the website's backincontrol.com. But I've seen such incredible success with these simple...
Just summarize that because you speak too fast.
Okay.
You said something very important. You have a website called backincontrol.com that all of you listening with back pain can go to, and you sent 2 people there. What
I
happened?
have sent 2 of my patients
Okay.
there since we've met,
Okay.
and one of them actually dropped out. So I
Okay.
don't know what happened to him, but the other one is just incredibly happy
Oh, cool.
and is following your program and the things that you're talking. And he said he sees the light for the first time in probably 15 years.
So I'm watching that happen all the time. People getting pain-free with no risk, no cost, nothing. And I watch them being badly damaged by spine surgery. I just had to quit. So I really did quit. I'm really committed to trying to get this out to the world. And every week, another physician or 2 comes on board. A physical therapist comes on board. I get to do podcasts like this, which I really appreciate. But yeah, it's a big problem. And the message needs to get out to the general public and mainstream medicine that this is just data that's been proven for centuries. This is not new stuff.
Well, what you're doing is fantastic, and we're so happy to support you today and hope to continue to support your wonderful work in the future. And thank you for giving up a lucrative career to be helping people for free, but perhaps you're now gaining a new form of wealth and riches. I haven't charged anyone for psychotherapy for at least 25 years, but I treat people all the time, and there's nothing better than seeing people recover and participate in that miracle. And so neat to see you're doing exactly the same thing from the other side of the medical divide. And I'm just so proud of you and proud to know you and just grateful to have you with us here today.
Yeah, no, thank you very much. As you know, I'm a huge fan and I appreciate your work. I honestly wouldn't be here without it. So, it's been a huge factor in my work, and I appreciate this opportunity very much.
Yeah, thank you so much. I hope you come back and talk about how pain affects families.
Okay.
We have no commercial messages today except to say that the podcast is growing. And if you like what you're doing, tell your friends. You're our main source of marketing, word of mouth. We have a lot of free resources on my website, feelinggood.com. The podcasts are just one of them, and a lot of wonderful resources for you at www.backincontrol.com. So thank you so much.
Thank you.
This has been another episode of the Feeling Good podcast. For more information, visit Dr. Burns' website at feelinggood.com, where you will find the show notes for this episode under the podcast page. You will also find archives of previous episodes and many resources for therapists and non-therapists. We welcome your comments and questions. If you want to support the show, please share the podcast with people who might benefit from it. You could also go to iTunes and leave a 5-star rating. The theme music is Gypsy Jazz in Paris, 1935, composed and performed by Brett Van Donsel. I am your host, Rhonda Borowski. We hope you enjoyed this episode. I invite you to join us next time for another episode of the Feeling Good podcast.